My name is Carol Kruchko, as Joanne has just stated, and I am President, Founder, and Chief Mission Officer of the Central Brain Tumor Registry, known as CB Trust. And I'll say that again as I've moved away, CB Trust. And I want to thank the conference coordinators for inviting me. And now I need, since I'm not, oh, here we go. And it's an honor, actually, to follow my clinical colleagues. As you've heard, they all take wonderful care of your children, are very invested in research and in improving treatments. This is one of my favorite slides, and it's from a cover of the International Brain Tumor Alliance magazine, and it's of a Dr. Wolf who works at Tufts Children's. And you can see that the care is there, and under the circumstances and the knowledge that we know, everyone tries their best. So the clinicians that just spoke are treating the patients. They're treating your children. Epidemiology, which is what we do at CB Trust, is really looking at the patterns of childhood brain tumors in the population. So our analysis look at childhood brain tumors we looked at them by other cancers, by age, location, site in the brain, histology, gender, race, and Hispanic ethnicity. It's important, the data are reference data. You've heard mentioned a couple of times data. The data aren't there yet. We don't have enough information. Well, the data are there from the population, and that's what we are doing, measuring what is going on in the general population for childhood brain tumors. We also do this for adult brain tumors. But the data give us this reference point. When these docs and researchers go in and try to advocate or get approval for a new drug, say from FDA, they need to have reference data. Many of the drugs are for rare cancers. We need to prove that these are rare cancers. We all know this, but FDA requires this. So our data are very important for reference data. They're also very important for public health, for clinical, for patient planning. So we're looking at the incidence, how many brain tumors in children overall. So the incidence, and we look at them in two age groups, 0 to 14 and 0 to 19. And in the 0 to 14, we look at the incidence is approximately 5 per 100,000. And this looks that we're looking at over 16,000 tumors, and these are over 5 years. Cancer registry data are presented in 5-year increments. So if we look at 1 year, and in 2016, it was really estimated that we had about 34,000 brain tumors in children. If we look at the 0 to 19, and you might wonder why we say 0 to 19 and 0 to 14. 0 to 19, the clinicians like this age group. So we try to make our data very relevant and reflective of what the clinicians see. So in the 0 to 19 year group, our rate is about pretty close, 5.42 per 100,000, and we have approximately 22,000 tumors for the 5-year age group, 5-year 2007 to 2011, and this is approximately 4,600 new cases in 2015. If we look at the prevalence, that means how many children were diagnosed in the years that we're talking about, but are also living. We're looking at approximately 28,000 children are living with brain tumors. And these data come from looking at children in 2004. We are currently updating this manuscript so that we have more current data, but you do need to have a certain number of years that pass in order to do prevalence, because you have to know how many children have survived. So if we looked at the incidence of brain tumors in relation to other childhood cancers, so that you have a frame of reference. We know they're exceedingly rare, but did we know that really they're the highest incidence rate of all childhood cancers, with leukemia being second? It's very important when we look at childhood brain tumors that we look at where they are located in the brain. At the turn of the century, there was a very famous neurosurgeon by the name of Harvey Cushing. And Dr. Cushing made the observation that some brain tumors are malignant by histology, and we all know what that is, the type of tumor, whether it's a pilocytic or an atypical pterygoid rhabdoid tumor. But some are malignant by their location. And if we look at the diffuse intrinsic pontine gliomas, and they're divided into low grade and high grade with different histologies, we know that their location, being on the pons, could be very lethal for these children, and prognosis sometimes isn't very optimal. Some, like we just heard someone talk about their child having a low-grade pilocytic astrocytoma for many years, and it was just a watch and wait tumor. Those are wonderful pontine gliomas, but many of those we can't even do biopsies to know exactly what the histology are. So if we look at the distribution of all primary brain and CNS tumors by site, and we're looking now at the 0 to 14, and the cumulative number is over 16,000 tumors, we can see that the majority of these tumors are in the cerebellum, and that's the back. If most of you probably already are familiar, it's in the back part of your skull. And this is then followed by the frontal and temporal and parietal occipital lobes of the brain. The cerebellum tumors are really for the younger children, 0 to 9. The other tumors are as the children age, from 10 to 14 years. So facts about histology. We know that over 100 different types of brain tumors, and maybe some of you have read that this is a larger number. Joanne once asked me for this, and I went to the definitive book, which is the WHO classification of tumors, and counted them. So there are 100 different histologies, but sometimes we mix nomenclature, or we include some of the molecular markers and the definitions. We add those to the histologies. But there are approximately 45 histologies found in children. As I said, WHO classification is the holy grail of tumor histology. And at this time, that is undergoing revision, and it will be a new layered revision with the molecular markers that we've heard so much about through the genomic studies that are being done. This will help give more accurate descriptions of the tumor, which will help with the treatment prognosis of these tumors. So it's very important, and we're hoping we will see that new classification system coming out in the near future. I think next year, actually. Now, CB Trust has a histology grouping scheme. And our histology grouping scheme, I will show that in a minute, is based on WHO classification. We're in very close contact with the neuropathologists who create the scheme so that it is clinically relevant. We work with 3 in particular to vet what we are seeing them and correlating that with the cancer surveillance community. And I think the young woman in the purple asked a question about, having a profile of the tumor that your child has. There is a new standard that has been issued by the College of Pathologists, and this is a recommendation to all pathologists who are looking at brain tumors in adults and in children that depending on the specific histology, they have a list of markers that they would like the pathologist to look for. So things are changing. It's just a slow process. There are many layers of responsibility and creating which markers need to be looked at. Not every brain tumor histology has molecular markers that are attached to them. There are only specific histologies that they have found these markers. As research develops and more histologies are studied, then we'll know a little bit more. So the CB Trust histology grouping scheme, this is what it looks like. This slide is very busy, and I don't know if you have any handouts, but I'd be very happy to give you some. But this is because of the rarity of the tumors in children, we have to group them in order to have any kind of meaningful data to present to you. And so we group them. We also group them high and low grade because this is an important way of looking at them, especially for the genomic studies, looking at high grade versus low grade. There is another molecular scheme called the International Association of Cancer Registry Scheme, and that scheme is also used. We happen to like the way our scheme works because we've actually been working with the clinicians. So if we look at the distribution of all childhood primary brain tumors, and this again is in the 0 to 14 year age, we'll see that the majority of these tumors are gliomas. Now remember, glioma is a very broad term and includes other tumors. And so if we look at gliomas, we can also look at the pilocytic, which are the largest number of tumors, age-adjusted by age groups. In the youngest, that is the less than 1 year old, we'll see that the incidence is the highest. Now you're going to say, but the number is the lowest, but we're looking at a proportion, so it's incidence. And so the highest is, it's a rate. So the highest is in our youngest children, the infant age group. And then our next highest incidence is in the 1 to 4 year old age group. And the incidence in the under 0 or 0 age group, we call infants under less than 1, 0, is 6.28 per person years. And this pattern was stable over the entire time frame of our data, which is 2007 to 2011. And if we look at age-adjusted incidence rates by age and behavior, and this slide includes adults as well, we'll see it, but I put it here because I wanted to, this is really because we have an enormous number of meningiomas, which are the most common brain tumors of all brain tumors. And this year in our data, we have discovered, and these data are our data from our previous year. Our report was just submitted for publication to Oxford Press last week, and it'll be probably up through the journal Neuro-Oncology this coming week. And we are reporting this year for the first time that pituitary tumors will be the second most common brain tumor. And pituitary tumors have a very high incidence in the young adults. So we're talking the 15 to 19 year old and the adolescent and young adults, which is really 15 to 39. Again, we have to remember that our age distributions are what surveillance normally reports tumors. And again, that's why we try to have ours clinically relevant and to report these tumors, by 0 to 19 and break them up into different age groups, which is what our clinicians would like. So if we look overall at brain tumors, approximately 52% of all childhood brain tumors in the age group 0 to 14 occurred in males, and 47% occurred in females. Again, this changes with adults. Overall, the median age is 7 years old. The pilocytic astrocytomas were the most common childhood brain tumors, with about 1,500 occurring in males and about 1,300 occurring in females. The lymphomas and the hematopoietic tumors were the least common of all the childhood tumors in the 0 to 14-year-old, and we had only over these 5 years 70 tumors and 24 total tumors in females, so 70 in males and 24 in females. So you can see how rare these tumors are. Choroid plexus and the atypical teratoid rhabdoid tumors had the lowest median age of diagnosis, 1 year for both males and females. So if we looked at by histology, the incidence rates by histology and race, overall brain tumors are higher in whites than in Asian Pacific Islanders and than in blacks. Gliomas, age-adjusted incidence of approximately 3 per 100,000, and the embryonal tumors with less than 1 rate per 100,000 were more common in whites as well, ages 0 to 14. The pilocytic astrocytomas also followed that, but the germ cell tumors we found were, and the tumors of the cranial and spinal nerves were more common in the Asian Pacific Islanders. And these are groups that the surveillance communities have designated. So that's how we follow our designation with ethnicity and race. So if we look at tumors by histology and Hispanic ethnicity, we can see overall the incidence was higher in the non-Hispanic. The age-adjusted incidence rate is just a little over 5.6 per 100,000 population in Hispanic, and it's 4.5 in the Hispanics. Right, it's higher in non-Hispanics. Atypical teratoid tumors and the lymphomas, the age-adjusted incidence rate was 0.03 per 100,000 population, and they have the same incidence in Hispanics and non-Hispanics. The anaplastic astrocytomas, age-adjusted rate, which is under 1, versus the glioblastoma, which again is also low, 0.09. We see that they have a similar incidence in both the Hispanic and the non-Hispanic populations. The pilocytic astrocytomas had the highest age-adjusted incidence rate in non-Hispanics than in Hispanics in the population. So if we're going to look at relative survival in children and 0 to 14, overall relative survival is better in the older children. So 5 years survival in children 10 to 14 years was about 79%, as compared to infants, and remember that's in less than 1 year of age, was 55%. The pilocytic astrocytomas have the highest survival rates with diagnosis after 1 year of 98% and 10-year survival of 95%. So that's really wonderful survival for those children with these tumors. If we look at the atypical teratoid rhabdoid tumors, which we refer to as ATRTs, they have the lowest survival after diagnosis, with 1 year survival of about 48% and 10-year survival of 25%. This is really so much better than in previous years. We look at groups of years for survival, but these tumors did not have the prognosis that they have now in the new treatments that are coming out. So we see an improved survival for the ATRTs. So if we're looking at distribution, total deaths to primary brain and CNS tumors in children 0 to 14, if we look at these by histology, and between 2007 and 2011, we had only 734 total deaths. Remember, this is 5 years. So this shows that, you know, the clinicians are really treating our children with and getting much better results in recent years. So the high-grade gliomas cause the greatest proportion, and that's 43%, followed by the medulloblastomas, and the which is about 14%, and the ATRTs. If we look at distribution, which means by site, where they are, and it's not surprising that the brainstem, the death mortality rate would be lowest for those tumors since they are so difficult to treat. The cerebellum has 16.9%, and that's where probably most of our medullos and peanuts are located. So there is something called 5-year conditional probability, and this is what conditional probability is. If a child lives 1 year, what are the chances of living 2, 3, 4, 5, 10 years? And so conditional probability, and again, we have just submitted a manuscript on conditional probability to make the data more current, because data changes, and we all know that children treatments are better, children are living longer. So looking at conditional probability, time of diagnosis with a high-grade glioma, we have the 28% probability that a child is going to live an additional 5 years if they've lived 1 year. Survival for can't read this. For ATRT, if you've lived 1 year, you have a chance of living 27-point chance of living 5 years. So we can see that there has been improvement, and this is something that you can ask your clinician, or you can look at our data and feel comfort, I hope, that you've made it past that 1 year mark with your child. Now, CB Trust, besides presenting data in a report and looking at data overall, we take our data and we do special studies. And again, this was a study that one of your own Pediatric Brain Tumor Foundation people that are here, Joanne, was a co-author on this study. And Joanne came to us and said, you know, our patients, the children live, but they live with their tumor. And those years are not carefree childhood years. We all know how difficult it is for families and mostly for our children. Is there some way to measure this? So we looked at looking at the years of life lived as opposed to the years of life lost. The years of life lost would be your child has passed away, and all those years have been lost that we had hoped to see and grow with our children. Years of life lived are the years that your child actually had to live with their tumor. So we did this study, and Joanne doesn't know this, but it was so well received that we are now looking at years of life lost and lived in adults. So that will be coming out, and we thank Joanne and the Pediatric Brain Tumor Foundation to bringing this idea to us. And so I encourage you, if there's some question that you have, there might be some way of measuring this and giving you back some data. We work with all these numbers and statistics, and we're not always with the patients. This is a unique opportunity to come and talk to the patient community, even though I have to share that there was a time over 25 years ago where I sat where you sat. So I understand where you're coming from, but we mostly will speak at scientific meetings. So we're very, very happy to be allowed and asked to speak here today. So years of life lost, lived. Among cancer deaths, brain and CNS tumors cause the greatest proportion of years of potential life lost, followed by leukemia. Gliomas, in particular high-grade glioma, were the biggest contributor to years of life lost. And brain tumor histologies that led to death varied significantly by age. So age tells us, and this is one thing, as we look at our data, we look at it by site. You're probably wondering, why are you looking at it by site, by gender, by age, by all these different ways? Because they give us clues as to maybe why does a particular tumor occur in this age group. Our data are here to provoke these questions, not to answer the questions, just to provoke questions. And some of them you might have as you've listened to what I've said. So we also look at trends. This is over time. What has changed with tumors over time? And the C little diagram there pertains to children. In children ages 0 to 14 years, there were increases in incidence of acute lymphocytic leukemia, non-Hodgkin's lymphoma, and also in malignant brain tumors. We've all heard that cancer overall, the incidence is decreasing. It isn't decreasing in our children for malignant brain tumors. Why? We don't know. But this will, maybe someone will investigate what the reasons are and look into causation. In adolescents 15 to 19 years, there were increases in the incidence not only of malignant but of non-malignant. And those non-malignant tumors are the pituitary tumors. I told you are now the second most common brain tumor over all ages. So I mentioned ATRT. This was a highly malignant tumor that occurs in children under 3 years of age. I like to, and I don't think anyone really has ever said this, but to me, this is the glioblastoma for children's tumors. The average annual age-adjusted incidence, you can see, is under 0.1 per the rate per 100,000. And the 6-month, 1-year, 5-year survival, 65%, 46%, and 28%. So this is has gotten more attention. When I attend scientific meetings, ATRTs are studied, seems more in the recent years. And there are molecular markers that they help with prognosis and treatment of these tumors. So I know some of you are going to have questions about causation. There are we've studied, other epidemiologists have studied environmental factors. Ionizing radiation is the only recognized causative factor. We know this from a study in Israel. Most people who immigrate to Israel are checked, and one thing they're checked for is ringworm, which is called Tina capitis. And if they have this, they are radiated, which is cures this, or at that time did. Or at that time was the therapy that was given, until years later they discovered that in that population there were many meningiomas. So we can equate that ionizing radiation is a recognized causative factor. Gliomas are associated with some rare familial syndromes, like Liefers-Mini syndrome. But we have, to date, there's no increase risk for gliomas with cell phone usage. In Europe, they are doing another study looking at cell phone with children. The original studies were done when we had those big bulky phones and the system was different than it is now. People ask me, what do you do with your own children? And just take the precautionary principle. You know, if you can use it, let them use earphones. Don't let them sleep with their phone under their pillow. Some of my children did that. They don't want to miss any social thing that's going on. I don't advise that. And with males, don't let them carry it in their pockets either. Or girls too. Just, put them in their backpacks. So our office is in Hinsdale, so I'm about half an hour from here. We have this, our office is the administrative office. All of our data analysis are carried out at Case Western Reserve University, and our analytic team is Dr. Jill Barnholt Sloan. Our analysts that work under her are Quinn Ostrom, Haley Gittleman, Yaowen Chen, and Yingli Walensky. And this is the most fabulous team. They are very productive, very responsive, and I've enjoyed and hope many years to continue to enjoy working with them. I'd like to thank all the researchers who made the data which I presented possible. Remember, the data starts with your clinicians and the patient records, the medical records. The tumor registrar goes into the goes and looks through these records, enters it in to a report. This report eventually goes down to a central cancer registry. All states by law have to have a central cancer registry. These data then go to two places. All of them go to the Centers for Disease Control, CDC, and we pick the data up. We have an agreement with Centers for Disease Control, and we pick the data up there. And some states, which do more in-depth collection of data, send their data to NCI for their SEER registry there. So I want to thank everyone who's involved. We couldn't do it without all these people. We wouldn't have these data. And they are reflective of the entire population, which makes them excellent reference data. And of course, I'd like to thank those who have financially supported us, the American Brain Tumor Association, which always funds our publication of our report, the Sontag Foundation, Genentech, Novacure, Electa, the National Brain Tumor Society, Musella Foundation, and the Zella Doran Memorial Foundation, and individual funding that we do receive in in-kind donations. And of course, we have a grant with CDC that also helps us with covering our costs and of all these analysis. So I thank you, and hopefully we will see each other again. And I thank you.